All right, guys, I think we ought to get started here because we are already 10 minutes late. We have a lot to cover here. So we're going to talk today. For people here that don't know me, my name is Rodrigo Lago. I'm one of the interventional cardiologists here in the hospital. So we're going to talk today about something that it could be a little blunt, but it's so important that I think it deserves a grand round. So we're going to talk about vascular access, but we're going to talk about this in the context of the new era that we live right now, where we are doing more advanced therapies and more complex things in the cath lab. So we're going to discuss here today a couple of things. We're going to discuss a little bit about the radial and femoral access, talk a little bit about the origins of all that. We're going to just touch a little bit on some alternative access that we have available today, and the current implications that this could have for us in the future, and in the present and in the future. We'll not talk about vascular complications, treatment, closure devices, techniques of catheterization, things that are not interesting at this point. We're not going to talk about arcane vascular access techniques and things that are very, very uncommon. So we're just going to start at the beginning just to have a perspective where we are right now. So in the past, we didn't invade bodies and arteries. And not very long ago, in 1929, this guy here called Forssman, I think he was a resident, radiology resident. He inserted bladder catheter in his brachial vein, walked down to the radiology department. The catheter was all the way into the right side of his heart, and he took this picture here. That's considered the first angiogram, and I think he got the Nobel Prize for this. I was not alive. So in 1953, Dr. Seldinger changed everything. He started the technique of, and that's pretty much the technique we use today to go inside the arteries and veins, insert a needle inside the vessel. And Dr. Seldinger, at that time, when he started doing this, he went what we call through and through. He went to the front wall, back wall, withdraw the needle, and then put a wire through to get his catheter in. Now we do a little bit modified version of that, where we don't go through and through the back wall, we just go in the front wall. But that was a revolutionary technique at that time and changed the way people access vessels. Dr. Soames, Cleveland Clinic, 1958, he started doing brachial access for his catheterization. So he used the catheters inserting the brachial veins and arteries. But at that time, what they are doing really are measuring pressures. So Dr. Soames one day was trying to take an angiogram of the right side of the heart and the left side of the heart, and by mistake his catheter went into the right coronary artery. And at that point, people thought that if you inject contrast in the coronaries, you kill the patient. So by mistake, he took that picture. That's the first coronary angiogram that was ever taken. That was done by Dr. Soames in 1958. Dr. Soames developed catheters that were specifically designed to engage coronaries, and that was probably the first time that people really start doing coronary angiography using pre-shaped catheters called Soames catheters. I have the chance of using these catheters. They are not as good as the one we used before, but they work. So Dr. Judkins came and he created something that's called the Judkins simplification. He created pre-shaped catheters that really, really folded in a way that shaped inside the ostium of the coronaries. And that changed everything, because then he started using femoral access for all his catheterizations. He moved from the brachial to the femoral, because his catheters could fit perfectly in the right coronary and the left coronary, so he could take perfect pictures using femoral access. And those are like little examples of these catheters. The catheters that we still use today, they're called Judkins catheters. We have different catheters nowadays, but this is the most common catheter, the shapes of catheters that we use in the cath lab when we're doing catheterizations. And that revolutionized the way people did catheterization. They started doing more femorals, and femoral became the gold standard for catheterization. Femoral artery access and femoral venous access. This is for arterial access. So the femoral artery access, it's simple, but it's complex. If you follow the anatomy, back one. So if you follow the anatomy here, you have the artery and the vein. Right next to the artery, you have the nerves running right here. And you have this artery here that's above the inguinal ligament. And the problem here is that if you stick your needle in the wrong place, you get in trouble. And that's the problem that we have today. When you do catheterization and you put your needle in the wrong place or your catheter in the wrong place, you can cause problems. You can damage the vessel. And it can cause real long-term issues in the patient. So we try to use techniques to avoid this and use landmarks to try to get the catheter and the sheath and the needle in the right place. So that's a couple of pictures here where you can see the catheter is inserted in the femoral artery, the common femoral artery. And on the left side, a little bit of a high stick. And there's one a little bit in the low side. So different levels of places that the needle can land. But there's a specific place where you want your needle to be when you do a femoral access. So you want to be someplace around the center of the femoral head. So any place above that, you increase your risk of complications. Any place below that, you increase your risk of complications. But when you look at this, when you look at this series of patients, this is a series from New Jersey, from Dr. Turan. They look at patients where they end up sticking the catheter in a blind stick, like the way people do it without any ways to see where the needle is going besides just using anatomic landmarks. Most of the time, you get the needle in the wrong place. You get the low stick, which is not bad, not worse than when you have a high stick, but this is not good. So most patients got in that spot. Very few got in the high spot, but this very few could have bad complications. This is life-threatening sometimes if you cannot have a good stick and the stick is high. Because the problem is if you have a stick here, you don't have a place to compress the vessel after the procedure. So you can run into trouble. So the trouble on the top, on the high stick, would be retroperitoneal bleed. And I'll show some examples of that. That's just showing the percentage of patients. So you want to try, and try to be in what we call the target zone. The target zone will be someplace around the center of the femoral head. So, and you definitely want to be below the inferior epigastric artery, because that's, every time you're above that, then your risk of bad complication, bleeding, is much higher. So the key to have a good access in the femoral artery is to, first of all, try to avoid these areas of high risk of complications. But there's some tools you can use to decrease this risk. So the tools that we have available now to decrease this risk are, one is called micropuncture. It's a very, very thin needle that if you end up going in the wrong spot, you can withdraw the needle and try a better spot, because the needle is very thin and the bleeding is very minimal compared to the needle that we use in a regular basis to access vessels. We use fluoroscopy guided, so we take a fluoro, like an X-ray, at the time of the procedure and see exactly where the needle is landing. And we can use ultrasound guided to help us identify the artery and the vein and go exactly where we want. So if you want to access the artery, you go on top of the artery. And if you want to see go on the vein, you just go on the vein. So you can see it with the ultrasound. It makes it really easy to access this without having any complication. But the combination of all of these tools can really decrease the complication rate in femoral access. and you want to have your needle in the target zone. But it's very dependent on operator experience and a center, a hospital, an institution that is predominantly a femoral center. And I'll show you later what the impact of this and the ways we can access vessels. So the potential complications, like I said, bleeding is the most common, right? I'd say pain is probably the most common. People, they always have some pain. The pseudoaneurysm we see very common. AV fistula. Sometimes they're small, sometimes they're large, sometimes they can be treated with a very conservative way, in a very conservative way, sometimes they need surgery. So it's a bad deal. You don't want to have that. You can have nerve damage. You can have all these complications here. So you want to try to avoid this. So that's why femoral access, because it was so widespread used, and we see complications that has a bad name, a bad reputation. Some places more than others. So the predictors of complications, I'll show you like the most important one that people talk all the time is female, old, and low body weight. But if you low body weight has a higher risk of bleeding. A high body weight has a risk of bleeding because the access is more complicated. But usually when you have a high body weight is also increased risk of, but it's less than the low body weight. Low body weight is shown to have more risk of bleeding than obese patients. Obese patients, a lot of times you would either take more, be more careful with access, or you use other access. And we'll talk about that a little bit. But the vessel size and the vascular disease, the patient has significant underlying peripheral vascular disease, increases the risk of complications, and the location of puncture are very important. Renal failure, use of anticoagulation, and the time that you have the sheath in place. So if when you do an intervention, when you put stents in, you have to use anticoagulation. So that increases your risk of bleeding significantly and increases your risk of vascular complications. So it's very different when you just do a diagnostic catheterization compared when you have to put stents in. So those are little examples of vascular complications. You can have something like that. That doesn't look good, and I know, Tara is here somewhere, and she sees this sometimes, and they're not happy when they see that, and we're not happy. These people have, when they have something like that or something like that, they need surgery. This is a bad thing. So, but sometimes you don't see that, but you can have a stenosis of the artery at the site of entry. You can have trauma. You can have a dissection. And this is the retroperitoneal bleed that we talk about. That could be dangerous, it could be deadly. So we try to avoid that. And now that we have more advanced therapies for valves and for congenital heart disease, we use bigger sheaths, bigger access catheters, and that goes from like a regular catheter where we do a stent, all the way up to the size of the catheter when we do a valve in, like a TAVR. And you can expect that this catheter here will have a much higher risk of having complications than this one. Right? 1989, this Canadian doctor, Dr. Campeau, he developed this technique of radial access. So the radial was very, very popular in the 90s. And became more popular with time. And he really developed a technique that is very elegant and avoid a lot of these femoral problems that we talk about. And with time now, it's being more widespread use, more in Europe than here. But it's being adopted in the United States really, really in a large scale, more CT. So it involves accessing the radial artery instead of the femoral artery, and using like a simple test to make sure that the radial and the ulnar artery is patent, so we can use the radial. We can use this in a very, very simple way, and a lot of patients will benefit from that kind of technique. still complications from that technique. So you can have pain, you can have bleeding like the femoral, you can have pseudoaneurysm. Pretty much all the complications that you see in femoral, you can have in radial. Although they're less, they're still present. You can have that. And hand ischemia is not a joke. If you have that, you can lose your hand. It's not good. Those are some complications of radial, because we don't talk about radial complications too much, because, like I said, it's very attractive, and people think it's an elegant way to do radial, but you can have very dreadful things that can happen with radials if you're not careful, especially if you're not well trained with radial. And that happens quite a bit. People that are not very experienced with radial start doing radial because of reasons that pressure from the market standpoint, hospital or patient asking for that, and they get into trouble sometimes. But there's some benefits. So it's a little less painful. Patients like it. Very comfortable. Patient can sit right after the procedure. The pressure, the time of hemostasis is shorter. Patient can go home same day after sometimes stents. So it's some very good aspects that we have to explore on that in the radial access. But there's definitely institutional benefits. So it's very, very attractive. So patients like that. So if you're a radial institution, people will come to do your catheterization of your radial access so they can go home same day and be happy. So institutions love this type of approach, and the cost in some studies has been shown to be less than the femoral. So there's some drawbacks from radial. So a lot of times when you do radial, if you're not very experienced, you have a high, what we call crossover rate. You start doing radial and then you have to switch to femoral because you cannot get the access to the radial artery, or you cannot have your catheters going all the way to the place you want. So you have to switch. That causes more time. It's more time intensive in the cath lab. So that's one of the most common problems. So a high instance of crossover. There's a limitation of the size of the sheaths and catheters you can use. So you can imagine radial is much smaller than the femoral. So you will have trouble putting big catheters in. And now, in times where we do more complex interventions, where we have to use atherectomy devices, and when you have to use a protective PCI, which is use of impeller support, things like that, it's very difficult to use radial access with that kind of technologies. And like I said, using any big catheters in the radial will increase the risk of complications significantly. You increase the risk of radiation, especially when you have to use the left radial artery. Every time you have to cannulate a patient that have bypassed before, and you have to go to the mammary artery, you have to go to the left radial. Left radial will increase the radiation for the operator significantly. So there's some drawbacks, and they have a longer procedure time, especially in centers that are not ready or used to do radial. So as much radial the center will do, more proficient, and less radiation, less time, less complications. So it's very center dependent. That's a bleeding definition. We're going to go straight from that. That's not important right now. So bleeding is a big deal. It's related to death. It's related to MI and stroke in patients that have procedures. This is from a large registry and large combination of patients from registry and trials. And it's a very, very significant finding that if you bleed, you have a very high chance that you're going to have a bad outcome. It is independent of access. If you have a procedure and you bleed, it could be surgery, intervention, catheterization, radial, femoral. If you bleed, your outcome will be worse. So when you look at the femoral versus radial, the attractive thing from radial is that the instance of major bleeding is less. And we'll go into more details. I want to try to go a little fast because Dr. Shah and Dr. Tossig, they want to talk. I know they, yeah. So And this is probably one of the largest trials comparing femoral with radial access. And it's in a group of acute coronary syndrome patients. And they compare radial with femoral in these patients. And the outcome of the primary outcome was not met on this trial. But the outcome of a major bleed at 30 days was significantly reduced with the use of radial access. This is called the RIVAL trial. And because of that, this was a trial that was published not long ago, but the use of radial skyrocketed, especially in Europe. This is, in some centers, about 95 to 98% of cases are done through radial access. That has some benefits and has some drawbacks, and I'll show that. That's basically showing the same thing. Bleedings, that's just just breaking down the bleedings on this study. A lot of these bleedings are they're non-access site bleedings, meaning they bled in the head, they bled in the GI tract. That's because of anticoagulation secondary to the procedure that was done. So not all the bleedings are in the access site. So when we look at the RIVAL subgroups, again, subgroup analysis is great, but it's not what the trial was designed to look. But when you look at that, you see that when you have a center that have a higher volume of radial, they did better with radial. But that was not true when they have a center that are used to do femoral. So if you have a center that lowest or middle tertile of volume for radial, the interaction was not there. And one interesting finding was that the STEMI patients did really good with radial. So that's basically showing the rate of crossover, that when you have a lot of crossover, femoral was favored, and the major vascular complications rate was higher with the femoral access. So there's no significant difference in primary outcome. So death, MI, stroke was same. But the rates of bleeding was lower in the radial access group, especially in STEMI patients and in high volume of radial centers. Okay? So that's another trial showing basically that the NACE, net adverse cardiovascular events, that basically major cardiac events, MI, stroke, death, and bleeding combined. So we show that NACE was lower with the radial access. So again, another trial showing that radial is very attractive. So then you remember the first slide when we have the STEMI patients did really good with radial. So they did a trial on STEMI patients. And they showed that bleeding was the primary endpoint in this trial. Bleeding and vascular complications was significantly lower in patients with radial, as expected based on the results from the other study. And also decrease in net adverse cardiovascular events. So that was a big study, matrix study that looked at a bunch of things. A little bit controversial study, but it was a big study. And I think on the matrix study, one of the most important things to look at was the anticoagulation. When we look at anticoagulation, the patients that did benefit from radial were the patients that had intervention, stents, and they use heparin. So if the patient received bivalirudin, Angiomax, for intervention, the interaction was not present, and femoral did the same. So femoral was okay if you use Angiomax in that study. And that's basically showing the same thing. I'm going to go a little quick here because you got to. So that's a meta-analysis looking at the same thing. And that study also showed the benefit of patients in terms of vascular complications and bleeding when they had radial access approach. That's a little bit too much information, but those are all the trials and the outcomes. So major vascular complications, major bleeding, significantly reduced with radial. MACE in this study was significant and all caused that. However, this is a meta-analysis, and you have all the issues, very, very high heterogeneity in this study. There was a lot of discussion about the matrix study. So looking at female versus male in this study, female benefit more than males for radial access because of the risk, because they have a higher risk of bleeding to start with. So the outcome for antithrombin type, we see that same result. So when you use bivalirudin, the benefit of radial is decreased, is less. So femoral is okay when you use bivalirudin. REVERE trial it was a trial that looked at radiation. Very big question of radial. We're going to have higher radiation exposure for the patient, for the operator. And this trial looked into that. And the only interaction that was found in this trial was that femoral had a much lower radiation exposure to the operator, especially when you're doing left radial artery access to radial. So left radial artery, you have more radiation. You have to sit on the other side of the camera where you don't have protection, so you get more radiation. A matrix trial look at the same thing, and they show similar things, but not a lot of difference between left and right. So this study was not a great study, but look at cost. So it showed that when you use radial access, you can decrease the cost, the overall costs of the procedure and the patient hospitalization. And that's because you decrease the risk of complications, decrease patient length of stay, and that can decrease costs. So that's attractive for hospitals, institutions. They like to save money, and that's another thing that push for to have more radial access use. So a very important thing, and that's a very interesting study, and that's one that has been looked really, really close nowadays. It's called the radial paradox. And just summarizing this, radial paradox is when you have a center that historically is used to do femoral, they start transition to do radial. You see an increase in vascular complications. And the reason for that is because operators are not experienced with radials in that center. Even if you start to implement, like to say, you have a center that's doing 30% femoral, 30% radial, and then you switch them to like 80% radial, you see a high rate of complications, vascular complications. These vascular complications will be femoral complications because people will lose their hands to do femoral access. This is a big deal because now we're doing procedures that require expertise on femoral access. You need to know what you're doing in the femoral when you're doing a TAVR, when you're doing any one of the advanced valve therapies or adult congenital heart disease procedures. You need to know what you're doing in the femoral area. So this is a big problem. Fellowship programs now, people are trained in some places, they only did radial. They don't know how to do a femoral access. And that's going to be a big deal in the future. Okay, so you have to be careful with what you want. You don't want to take from one side and then you don't have enough. Okay? So, and we are always behind. The United States is always behind. Europe is about at least 6 years in front of us. They are very, very good at radial. All the centers are doing better than we are doing here. Even the higher volume centers in the United States do worse than Europe.
For adoption?
For adoption. This is adoption of radial. So that's UK, and BCIS is UK, and CDR is here. So that's our adoption of radial is lagging behind at least 6 to 10 years. So we are late in that process. So we really have to be careful about this. Okay? So summarizing a little bit. So both radial and femoral are safe. If you're in good hands, you're going to be fine with both. Okay? If you have higher experience, you're going to have a higher benefit from femoral and radial. When you have a center with high volume of radials, go ahead and do radials more. But keep your femorals. the sweet spot, we don't know yet how many radials you need, what's the percentage that you're going to have a perfect center. You have a high radiation for a radial. You have to keep that in mind. We do a lot of procedures. You have to always think about that. So just the next one, just want to show you the new things that we do that require really good expertise in femoral. So if you don't know what you're doing with femoral and you access something like that, you can have bad trouble, okay? So this is like when you do a TAVR, for the people that haven't seen that. That's this type of cannula that we use. When we do ECMO, that's a type. This is a big cannula.
What size is it?
This is a 22 or 22. This is an old one, probably like an 18. This is an 18 TAVR. This is kind of hard to be a 24. Right? So it's a big sheet. And we have other access. I just want to touch on this because it's not really something that you guys are going to see, but you have to hear about it. There's other places that we can access. Transcarotid, transaortic, transcaval is a very, very sexy approach. People are using some places. So I'm going to stop here and give to Dr. Taussig first. And you have very interesting comments about that.
I'm just going to make a couple of comments. First of all, I think that was great. It gave you a little bit of the history. Forssman was a radiology resident that did the first cath on himself. He also got thrown out of his program for doing it. They took him back because I think he threatened to sue him or something. The second thing is Mason Sones, who did the first coronary angiogram, really made a big mistake. It turned out to be, I think Dr. Hurst used to say it was akin to setting your barn on fire and discovering roast beef because there was a cow in there. It was thought that you would kill somebody if you injected the coronaries, and Mason Sones wasn't paying attention, injected the coronaries, and that's how the first coronary angiogram was done. If you look at this data, I think the first thing is I worry a little bit about people just going to radial approaches because, as Dr. Lago said, many of the newer devices require a femoral approach, number one. Number two, it is clearly experience-based. There are studies that show if you use things like ultrasound or micropuncture or even just well, we puncture the groin. Number one, we line things up with fluoro. Number two, we actually do a contralateral angiogram. Our vascular complication rate with a device that is at the smallest 14 and at the largest 18 French is about 2%, which mirrors the bleeding complication rate of 2% that you see in these studies. And so you have to go ahead and it's experience. It's using your head and doing certain things that make it very easy to puncture things. Now, the last thing, and one of the things, and I'm going to turn it over to Dr. Shah, that I worry about is when we use these radial approaches, we damage the radial artery. There's anywhere from 2 to 17%, depending on the study you look, at risk of thrombosis of the radial artery. That radial artery becomes scarred, and in this era where we're doing more and more bypasses using vascular conduits, whether it be Lima, which we expect, REMA, or free radials, which we're seeing more and more of, I think that really burns a bridge from the standpoint of using the radial artery. And repeat catheterizations through the radial artery, there's often fibrosis, and it's difficult to do. So just some food for thought, and I'll turn it over to Dr. Shah.
Can you guys hear me with this? All right, you guys can hear me? All right, we're gonna lighten it up a little bit, all right? Really intense first half an hour, 45 minutes. hard to make a talk on access, you know, but actually it has a pertinent and applicable for our everyday experience. So, you know, when I first started, I was just taught how to do radials when I was in my training program. It was actually not that very much emphasized, but just an alternative to patients who had, you know, very difficult groin access. And fortunately, I was able to get exposed to that, and over time, I've actually increased substantially my radial access use for a lot of reasons. All right, so is everyone crazy? Probably not, okay? In the United States, like Dr. Lago said, we are slow adapters to new technologies, even new drugs. And, you know, the reality is that radial access is not new, as Dr. Taussig and everyone is, you know, when he trained, they used to do brachial stuff. And we even used to do brachial stuff as of just a few years ago. Now we've all transitioned to radials. So the reality is that about in 2007, there's only really about a 1% entire United States use of radial PCI. And this is just PCI, but PCI tends to mirror just diagnostics. And then over time, you know, even when you get crossover to 2012, you can see that the use of radial PCI has increased to about 16%. Now, as you go forward, you know, and you get more and more data, you know, as Ed mentioned, in 2000 up to 2012, it's about 16%. But now, even up to 2015, you're looking at 27 to 28%. I'll show you data here at what we do here at Florida Hospital, what we compare to the rest of the country with regards to radial PCI shortly. In the United Kingdom, it's almost up to 70% of cases that are being done either through the radial or alternative access. And in France, which I know is actually true, there's almost 80, 90%. It's hard to get people to use femoral access, you know, in other countries. All right. So what's really driving the change? I think it's sort of self-evident. There are different types of where our population has changed, right? We live in a day and a time where we used to be able to fit in a chair of an airline, and now that has changed, right? And we complain that the chairs are too small, where we're actually too big, you know? So access is really important, and you can see where the troubles would be for us in terms of management of patients who were trying to do a diagnostic catheter in PCI. Not too uncommon now is that everyone's on these poisons, as the surgeons would say, which is anticoagulation. And, you know, whether it's Coumadin or Eliquis or Pradaxa, you pick your poison. And we don't know this when the patient comes into the emergency room many times. They can't even pronounce the words. They say, well, we're not sure, I'm on a blood test. We just asked them versus this. And so many times we're not sure what they're on. Could you imagine when I did a STEMI maybe about a year and a half ago, I thought it was cool, I got access, everything is great, and then they told me the INR was 14. I'm like, oops, okay. And then the other thing is that, you know, as our population continues to become more obese, you know, the consequences of that obesity is diabetes and other vascular disease, and having access alternative to what you see here is certainly beneficial. And in addition, the reason why we're driven more towards alternative access is because, you know, there are complications noted with femorals. And my job today is not really to say that femorals is no way, Jose. It's actually we should be good at both, because we want, as an institution, to be able to do both whenever we need to, okay? There are advantages to femorals. We're actually quite good. I'll show you data with regards to that, but we're actually quite good with radials too as well. There is a learning curve for most things in general, as a lot of the students here and residents will see, that there are things that we just have to kind of work your way through, but once you get to that point, it's actually much easier. You become much more facile with it. So you deal with, you know, groin hematomas, pseudoaneurysms, dissections, other things like that, which can happen at any access site, okay? So you're gonna have to know how to manage both, okay? I know there are budding cardiology fellows here, that you're gonna have to manage both, okay? There's not just one way to doing things. So this is a Kim slide. So, you know, we live in an ever-competitive world, okay? I'm not saying don't do femorals, and I'm not saying do radials. I'm actually saying let's do both, because the patients are actually asking for it. They get on the internet, they look up Dr. Akala, they look up Dr. Taussig, they look up places and institutions that actually can do radials and femorals. And people will say, hey, listen, I want a radial cath. Now, the reality is that as operators, if we don't step up to that challenge and have the entire group of operators be able to do that, there's going to be an imbalance where the patients will either shy away from our institution or choose other operators that can do it. But they will go find what they want, okay? There are, you know, even fancy radial labs that, oh, sorry. There are fancy, I can't do this here. Yeah, radial lounges, people, and this is, I mean, these are, you know, advertisements, I get that, but this is the truth. The institution that I trained at, Henry Ford Hospital, okay, was almost 99% femoral, 99% femoral. The institution as it stands right now is about 60+% radial and about 30–40% femoral.
Our new cath lab at Kissimmee has radial labs built in.
Right. So it's not all gimmick. It's actually truly a part of our, you know, who we are as an institution, that we want to be that institution as a quaternary center to be able to offer all the services that we can offer and use the expertise of all of our operators. So we need to evolve, okay? And there are really three main advantages to a radial approach, okay? One is obviously what Dr. Lago said, is low risk of bleeding. The other is a shorter stay, you know? We sort of live in a fast break world, and sometimes applicable, sometimes really not applicable. But reality is that many times patients don't need to stay as long as they are. And then there's a potential cost savings per case. So if you ask me what the big deal is, as I mentioned, you know, improve patient comfort. The patients really, when they have had a femoral access and then they compare it to a radial access, it makes it, they'll tell you right up front. They walk off with a Band-Aid, you know, they walk off the table, they love it. There's a decrease in access site complications. Actually, our institution does fantastic with complications, okay? We have a very low complication rate, although it seems like it's a big deal. It's actually quite low. The radial artery is small, superficial, compressible. You know, it's easy to control. And the femoral access site also leads to complications. The decreased costs, you know, come without compromising a lot of things around. You know, we may not need as much staff. We can do same-day PCI, and people can leave much earlier. Potential savings per case, procedural success is equivalent, and also STEMI patients also benefit from TR. As Dr. Lago had mentioned, you know, there are 3 or 4 basic trials that have shown that there's really no difference in mortality, but when you look at vascular complications, the vascular complications are what kill you, okay? The surgical data in the literature will tell you every time you transfuse, the mortality goes up. Well, that's what happens when you bleed. You have to give transfusions. And we see that parallel in our interventional world, that once you have a retroperitoneal bleed and you start transfusing patients, and then you get into this dilemma, do we give the Plavix, do we hold the Plavix, do we do this, do we do that? The mortality goes up. I will skip through these relatively quickly, but this just sort of emphasizes that the vascular site complication and bleeding is statistically significant in terms of being less with radials. So the implications of this are both radial and femoral are equally safe, which we've tried to emphasize in this talk today. We're actually quite good at it, and I'll show you here in a couple of slides why we are so good, or how we are so good with our own data. And the clinicians, you know, ultimately will have to decide if they're going to sort of kind of roll with the times, or we are going to not offer a certain access site for patients. Okay, now there are hurdles to sort of overcoming this. You know, we need experience. It's tied to success. The volume also matters, okay? Anatomically, they're very challenging. If you have a CABG patient or an elderly patient or a short stature patient or an anatomic patient with anatomic tortuosity, that makes radial artery access or radial artery PCI much more challenging. There's a crossover rate. Usually it's about 6%, 7%, somewhere like that. The procedural and fluoroscopic times come with time. Once you get better at it, you get better at it. Radial artery occlusion, actually, there are much higher rates of radial artery occlusion, but with technique and intervention, when you do the radial artery, those rates have come down. There are really 2 main things that you can do to reduce radial artery occlusions. One is you give heparin at the time of your procedure, whether it's a diagnostic or an intervention. That markedly reduces your radial artery occlusion rates. And the second thing is a concept called patent hemostasis. When you put the TR band down, you actually put a pleth on there. You put enough pressure on there to resolve the bleeding from the puncture site, but you actually have flow that goes through the radial artery, and that substantially reduces your overall radial artery occlusion. Everyone talks about hand ischemia. That is a micro% of a micro% in terms of obviously devastating complications, but so are pseudoaneurysms and retroperitoneal bleeds. So there are complications on the other side. The challenges with radials also is in terms of the coronary anatomy. You have to be wise and pick your challenges. You know, if you have bifurcation lesions, osteo lesions, CTOs, or if you're doing rotational atherectomy, although you can do it, I've done it before, a little bit more challenging. All right. So this is kind of to lighten things up here a little bit. You know, we are resistant to change many times, okay? And they've done studies, you know, as to in terms of why we are resistant to change. And, you know, take it for what it is. But, you know, usually we kind of fight it, and then we understand that there are forces beyond us, that the world is changing around us. And then over time, we come to accept it, and then we actually kind of do well with it. There are really reasons for resistance to change, and I mention this because I think some of these actually apply to all of us, okay? It's a misunderstanding about the need for change because we've been doing it for 20 years. The fear of the unknown, lack of confidence, low trust, not being consulted as to why we need to change. You're telling us why we need to change. So there's a lot of reasons why people become resistant to want to adapt new technologies, you know, poor communication, change in routine, benefits and rewards. What am I getting out of this thing? So the implications, as I've mentioned, are such that now, I apologize. This is our own data here at Florida Hospital, okay? You can see that the purpose of this slide is to show, and I don't think this is how it was sent to me, so I apologize for being a little bit blurry. But these are just operators, okay? If you just look at several operators, you can see that their complication rates are low. We're good at what we do. We're good at what we do, okay? Groin complications from 2016 to 2017. Dr. Ackle, I apologize. This is the way the slide was sent to me, so it's a small font, okay? But I will tell you that in 2 years, so these are fun facts to know, actually. These are fun facts to know. In 2 years, we do 15,000 PCIs here over a 2-year time period, okay? In that first column, diagnostic catheters, if you look at our groin complication rate, okay, I will tell you it is 0.2%. That is our data. We own it. Not bad. Okay, not bad. If you look at PCI, we do about 5,000 PCIs over the last 2 years. Our complication rate in the groin is 1% of PCIs. So we're not as bad as we're advertised as stuff. You know, when we complain as interventionalists that the groin wasn't held and there was this thing and their thing, whatever, we're looking at it from a microcosm. But when you look at it in terms of an entire 5,000 PCI database, we have a 1%. And this is our data, okay? The radials, okay, of all the radials that we do, we have 0 vascular complications, 0. Okay. Are we competitive? Okay, the answer is yes. When we come from a perspective of complications, okay, again, a difficult slide, but I will tell you that if we have hematoma at the access site, how do you use it? Okay, right here. There we go. Our hospital here, rolling 4 quarters, okay? If you look at hematomas at the access site within 72 hours, the number is 22. The country is 22, okay? These are by definition, and Laura can give you the specific definitions, but if you just look at hematomas, it could be smaller, big, okay? Retroperitoneal bleeds, this is where we do the rock stars here. Look at that, 1.6% rolling 4 quarters, okay? Look at where the country sits, 6.1%. We're not bad. We're actually quite good at what we do. And the other vascular access site injuries, they're all about the same, okay? So what this slide really illustrates is the fact that, you know, we're very good at femorals. We're not asking people to change that. But where I'm asking, and I ask all the operators and those who are going to become new fellows, is become adept at actually other access sites because of all the things that we had talked about. So how do we stack up? Another slide. Okay. Rolling 4 quarters, okay, our hospital, femoral access. We are a 93% or so femoral access site. We do about 7% radials here, okay? The country, the United States, does 55. We almost do twice as many more femorals than the rest of the country does, okay? This is real data. This is from NCDR. NCDR is National Cardiovascular Data Registry, okay? Let's look at radials. This is where I think that we have enormous room for improvement. 7% is what we do, right? 7% of all of our cases we do. But this is for PCI, by the way. 7% of PCIs are done radially, okay, here at our institution. This is the one that blew me away, okay? You can't see it from here, from our side. 43% of PCIs in the United States are done radially. I almost fell down when I actually saw that. I asked Kristen and Lara to make sure that the columns and everything kind of lined up correctly. We weren't missing it. But, you know, when we live in a bubble and we see that we're doing it well, what we do well. But the world around us is changing, okay? The world around us is changing. In 2007, Google came about. In 2007, Twitter came about. 2007, Airbnb came global. 2007, Facebook became more global. The world changed around us and we didn't even see it, you know? And so what I ask people to do, particularly for the new fellows and the new trainees, is that you got to be really good at femorals. We're having large access site stuff. You got to know how to manage it. But at the same time, you will be trained how to do radials, and being good at it will keep you at a competitive advantage. All right, so why radials? Patients are asking for it. There are competitive forces, either colleagues, okay, C versus colleagues, or institution versus institution. They are going to use this as a marketing tool for good reason. Send me home. I want to go home. Doing my cath, get what I need to get done. Patients want to leave. Why is it so important for our institution? We are brandishing ourselves as a quaternary institution. If we don't get the casts done early in the morning, put a Band-Aid on them and say you can go home a couple hours later, they could be home at a reasonable hour coming from far distances. Okay, so it's a big deal. People are coming from far distances to see us. What an honor. If you've never really managed a groin problem, it is so painful. It's like waiting for something to happen and it's happening in front of you at the same time, you know? To follow up on H&H, look at the groin, how's the patient doing, blood pressures, this, that. It's really painful. We are dealing with a complex protoplasm. All this data that I'm going to show you right here, all this data is from the CDC, so it's all our United States government. You know, almost 40% of our population is obese. If you put an overweight plus obese, it's almost 70%. You know, we have a population that is going to give us challenges with regards to getting access to them. We have almost 6 to 7 million people who have AFib, so they're going to come in with poisons. Okay, you're going to have to figure that one out. And people come in poisons with heart attacks. They have therapeutic INRs, they have STEMIs. Okay, there are 10 plus, and there's probably a whole lot more people with peripheral arterial disease of all sorts of varieties. Okay, some of which is minor stuff, some of which is much more significant. And the reality is that we got to work our way around it. Okay, patients are going to ask for it. So in the end, all I ask is that I don't want you to choose one over the other. I want you to be good at both. It is very important from our department standpoint that any patient that comes to us, that we will be able to, any patient that sees any one of us, that we be able to at least offer them services that they're not getting shortchanged, okay, and be facile with it. Learning is always hard, you know, particularly when you're in the middle of your career or even starting of your career. You have to kind of work your way through it, pick the right patients and the right choices, get the right people to help you, and get over it. So that kind of ends my talk, okay? You know, we used to play with Intellivision and Commodores and Racks and all that kind of stuff. And my kid yesterday, the reason why I put this slide up, he's playing with his cousin in Chicago, with his neighbor 3 doors down, and they're having complex interaction with this game night, Fortnite or whatever it's called. I don't even know the name of it. But they are talking, and they have evolved. You know, we used to get together and play with Atari 5200. We thought that was the way to do it. Right? Pac-Man, Miss Pac-Man, Donkey Kong, okay? We used to think that was the way to do it, and we were really good at it, okay? We were really good at it, okay? But the world's changing around us. And I think that that data that I showed you, which was very enlightening, is to say that if we are at 7% and we do it really well, or if we are at 93% and we do it really well, wonderful. But the world is only doing it half of what we're doing it. We are not using radials that well. We are doing well with radials, meaning that we don't have complications, we can do it. But there's obviously room for improvement, you know, clear room for improvement. This is the world, this is our own data, this is the world around us, you know. And so we can close our eyes to it, or we can say embrace it to a certain degree and say that, yeah, we don't have to go crazy. If everyone just increases their volume by a small percentage, the overall volume is going to go up in general. The patients will enjoy it, your experience level will go up, and it will bring us in par, at least with where the country is headed. Okay? All right. Thank you very much, guys. Any questions?
One comment. I don't know if this is working.
You can turn it.
Yeah, one comment. I mean, we take credit for having a very low groin complication rate, which is astoundingly low. But I think, you know, we forget to mention that one of the reasons for that is we have great staff. The people that pull these sheaths, the management of groin complications, if they occur, when they occur rarely, so they're addressed in a timely manner, prevents a lot of disasters. And so, although I think we do a really good job with access, I think a lot of the credit does not go to the physicians, but goes to the staff that takes care of these people. And I want to tell you how much we appreciate that. And I'd just like to, you know, echo what was said by Dr. Shah and Dr. Lago. You need to be able to do both access sites or alternative access sites. I mean, I used to use axillary site, and I did train in the era when we did cut downs, et cetera. Those were really not that hard to get us to give up because everybody hated doing them. Radials, the first radial case I did was over 20 years ago. So it's a viable, obviously a viable alternative. There's a steep learning curve like there is with anything else, but I think we owe it to our patients to be able to offer multiple accesses and then choose the appropriate one.
Second, moderation, of course, is the key. And I had a professor years ago back in college said, beware the zealot. And I think we have to be cautious. The pendulum doesn't swing too far too fast. A question I'd have for our cardiology colleagues is that because the radial artery has not become standard of care with cardiac surgery because it's a different vessel histologically, it's a much more muscular vessel. We oftentimes use CardioZem drips preemptively in these patients. In these individuals, of course, with like you said, it's a very low risk. It's kind of like flying in an airplane. It's great till the airplane goes down. And loss of a hand is certainly a very significant event legally as well as from a patient's perspective. Do you do anything in these patients preemptively, treat them with CardioZem? And as Dr. Tausig and I agree, it's probably a one-time deal to do a radial artery access, at least for one side. But do you do anything pharmacologically? Because it is truly a different vessel. We see it, and Dr. Palmer would attest to this as well. Even post-operatively with a radial artery, we'll sometimes see maybe some ischemic changes because of spasm. Put them on CardioZem, it goes away. Do you do anything different with those?
Yes. So there are three things that come to mind that are pretty standard for things that we do with regards to radial artery access. First is we actually do what's called a Barbeau's test or Allen's test to try to make sure that we do our part to assess the circulation of the hand, okay? So that's relatively easy to do. The second thing is that once we get access, there are three medications that we really, actually four, that really help, okay? We use, and in my particular circumstance, I use cardine and nitroglycerin that give it intraarterially. And then you can also give heparin intravenously or intraarterially. So it addresses the coronary or the radial artery spasm portion of it, as well as the radial artery thrombosis portion of it. The other thing that often doesn't get as emphasized is the use of sedation. a lot of, particularly young women, when you use their radial arteries, they'll have a lot of radial artery spasm, and the use of sedation actually helps tremendously to try to help relax the radial artery itself, okay? And, and then on the back end, the concept of patent hemostasis, which is put the Band-Aid on, put the TR band on, which is your pressure dressing, but do it to the effect that you get enough for occlusion, but you're also documenting by plethysmography that you've got flow through the radial artery, okay? And all those maneuvers, relatively straightforward. Now, for surgical patients, I actually haven't been using the radial that much. I actually use femoral for several reasons. One is that in the perioperative phase, the anesthesiologist needs, the radial arteries for monitoring, and you may need it subsequent to that, or you may need it for surgery. So you pick and choose your battles, and I try to be selective about who the patients are and what they're getting. Yeah, go ahead.
Just a couple of comments. So to me, this is very analogous to the discussion about OPCAB and open coronary surgery, in which OPCAB has a lot of advantages for the short term, for the hospitalization, lower this, lower that. But long term, the reintervention rate may be higher in the OPCAB arena. So apropos to what Dr. Tauzik said, we are concerned about long-term utilization of these radials, and radials that have been beat up tend to calcify, and they're really very much unusable. But as Dr. Akela mentioned, it's really a secondary conduit and a secondary deal. Interestingly, what you were advocating in sort of obese people to go ahead and do a radial, those are the patients most at risk for having reinterventions or reops later on. So I mean, it's 6 1/2 dozen of the other. The other part is that if you're serious about coronary surgery, then OPCAB needs to be part of your armamentarium. So I would agree with your comment about armamentarium, but then the question is, to get to that point of expertise, how are you going to bring people along so that they're happy with the radials? Is that going to be the new role for that simulation device in the cath lab, or what's your plan for that?
They're going to have to tell me whether the simulation lab actually has radial artery. Okay, it does. All right, so there are many ways that this is happening. Right now, part of that battle is already being fought with us. Many of the new fellows or new graduates, they're only radial adept. They may not even be femorally adept, which is the other part of the spectrum, okay? So that's one. Even in my personal lab where I train, like I said, they're almost 60 to 70% radials. So the reality is that if you're trying to do it in the middle of your career, you have to pick and choose your battles, make friends, pick and choose your patient population that you're going to choose to do it in, line up a few. You can get people to come in and show you how to do these types of things. But it's really basic. There's no real magic potion to this. After a while, once you get across 50 cases or so, it's sort of just the light turns on, okay? You're able to adeptly manage the catheters. There have been times I did about 4 or 5 radials this week, and I think one of them or two of them I could not actually access the coronary, and that's true. And I still plug away at it because I know that the more that I do it, obviously the better you get it. And the same thing with cardiac surgery or whatever you choose to do.
Yeah,
Bill.
I just have a couple of comments. One is, I think for the surgeons in the room, and this is one of the complications we didn't really talk about with radial, there is probably the most common problem is a decrease in, especially for repeated radial cases, more than damaging the artery, is a decrease in your fundamental sort of tactile function. So when you're choosing patients, I think it's important if they really need that ability to work with their hands, use their hands, especially to very fine motor skills, then that's somebody I would not go radial on. I think that's important to say. The second thing is that I feel that, one of the things that the ACC, it's common dogma, really all this is about is radial access benefits the STEMI patient because we use such high anticoagulation in patients that are unknown, they're on poisons, et cetera. And the benefit to the patient, if you put it in time numbers, the door to balloon time can go up to 2 hours. And because of that trade-off with mortality with bleeding, you haven't hurt the patient, even though it may take you longer to do the case. I just wish that they would change that, so if you choose to go radial, now your time is changed to 2 hours for your door to balloon time. I think that would encourage more people to try that, and it would help the whole system.
Right, so but for radial STEMIs, I have to tell you, there's that, you have to walk before you can run. And I think that for STEMI population, there are very few operators that are actually feel comfortable. I mean, I personally myself would still default to the femoral for STEMIs, and I think most of us do at this institution, except for maybe one or two that have had an overwhelmingly higher experience.
Well, that's my point, is that's the barrier to, we're talking about patient populations who could benefit the most.
Right.
Is the
But it's
most
a self-fulfilling prophecy. It's a self-fulfilling prophecy in the sense that if you don't do enough, then you're not going to have enough experience.
Right, that's what I'm saying.
Right. So.
Yeah, and then finally, the funny thing to me is that, this is a procedure for obese patients. If you look at people who've had femoral versus radial access, the reason they prefer radial is one reason. They get to eat faster.
You get to eat with the other one too. It's fine.
No, but they got to wait. They got to wait at least 2 to 4 or 5, 6 hours and laying flat.
You don't have to. I certainly don't do that.
That's what the data shows, my friend.
Everyone wants to eat. For those who are watching online here, we do appreciate your time listening to what we're saying. Hopefully, you'll be able to see us. And if you have any questions or concerns, please don't hesitate to call or ask.